All right. Good morning. Good afternoon. Thanks for joining us today. This should be another super fun show. I've got somebody on here today, Steve Alley. We're going to talk about strategies that are going to take the pain out of healthcare renewal season. And I think some people were confused maybe by the title and some of the topics, but we're going to cover a number of different subjects today. But really, the idea is how do we get ultimately when people are paying for healthcare and when employers are evaluating healthcare options and things like that, ultimately, what is it you want, right? Nobody like gets into business because they want to offer benefits or because they want to make decisions around how to handle the healthcare spend and all of those kinds of things. But ultimately, I think all of us as human beings just want to know that we are able to get in and seek care and get the attention that we need to ensure that we live a long, healthy, productive, prosperous life. And so putting that back at the center of this, not necessarily, okay, here's these cool strategies around direct contracting or reference based pricing or medical management or all these other things that we talk about a lot. Ultimately, what we want to be able to do very simply is we want to get in and see the doctors that we need to see and get the care that we want to get, that we need to get in order to live those healthy, productive, happy lives. And for that of our families, but also for our employees. And whether you like it or not, in the way that this system is set up, people have been conditioned to believe that their employer, in many cases, ought to be the one that's providing access. And this is something that's baked into our compensation packages these days, right? So, with all that in mind, it's become a very expensive thing. It's become very opaque and fragmented and confusing. And ultimately, we're going to talk about some strategies today that are going to simplify things and take things away from this traditional health insurance model as a way for you to access the healthcare system into something that's more akin to any other kind of transaction that we're using in our daily life, and that type of thing. And so, one of the things I always talk about is when you think about if you were to ask somebody, well, what kind of healthcare do you have, or how's your healthcare? What they'll talk about is the insurance company that they're working with, right? They'll say, well, I've got, a big network because I've got this insurance carrier, or that insurance carrier. But if I asked you what kind of car you drive, you wouldn't tell me, Geico or State Farm or whatever your auto insurance is. So it's a very it's a very convoluted conversation in many ways. So we want to shift that paradigm today, and Steve and I are going to do that. And so we're going to talk about a number of different strategies that we've used that we've seen successful, and how to kind of pair those together and marry those up. And so I'm really looking forward to this. Steve is somebody I've been working with for the last a couple years now. And as I say, we've had a chance to work together quite a bit. And he's really opened my eyes to some of the things that I didn't realize were possible, even in kind of the non-traditional way that I look at healthcare and accessing healthcare and such. There was a couple of strategies that we've been able to put together and been able to work through, and it's been a really good fit for my clients and also for GBS, for Group Benefit Solutions, because one of these strategies that we're going to talk about is something that we ended up implementing at our firm. So I like to say we here at GBS we eat our own cooking. And so some of the strategies we're going to talk about today are exactly what I'm using for my family and the rest of our staff is using as well. So anyways, for what that's worth, I felt like that was something you need to know. So again, thank you guys for joining us today. Without further ado, I'd like to introduce Steve Alley. Steve, if you could give just a brief background to the folks on the call here this morning, let them know kind of your background and how you came to find some of these strategies that we've been deploying now for the last few years.
Yeah, sure. Thanks, Chris. Yeah, and you said all this very well. I mean, I started in this industry like most people. I got into this industry by accident in 2009. I don't know anybody that does this on purpose, but
No, there's
here
very
I am.
few.
Yeah. I started out on the voluntary benefits side because that was kind of the easiest entree at the time. And then as you start talking to clients, you start learning what's going on in that client, what their real pain points are. And the real pain point wasn't that we needed a better accident plan or a better disability plan. It was my health insurance is killing me. And that would, I mean, this goes back to probably the teens. So it was getting worse as we went on. And then each year it kept getting exponentially worse. So we started out, we did some level funded plans. I never really got into self-funding. I wasn't that smart, so I couldn't put all that together. But we did some level funded stuff. We were trying to do some different things. And we even started marrying in 2017, 2018. We started marrying in some MEC plans with medical cost sharing as an option. So thinking, hey,
Yep.
let's look at this. Let's let a few people take this, and you have your group plan. The problem with that was it took away from the group plan, and they didn't like that. So there was this whole fight back and forth. Then in 2020, I discovered, because I had a relationship with one of the medical cost sharing companies, I discovered this solution that we're working with now that's evolved into what it's become. And it was all around the individual coverage HRA chassis.
Right. The ICHRA.
The ICHRA chassis. Now, the problem with ICHRA is that, and I watch LinkedIn and I watch all my colleagues talk about this, and all they do is talk about ACA plans and what are the limitations here, what are the limitations there. That's not the secret of this whole thing.
Right.
The whole plan hinges, the whole ICHRA idea hinges on letting the employer get out of the group health plan business, like you said, and offer alternative ways for their employees to access care. Which means, yes, you can have a traditional individual plan on or off the exchange, and the company can contribute to that. But more importantly, excuse me, more importantly, you can also offer non-traditional options that let your employees completely opt out of the ICHRA side of things in the traditional world and into something different. Like it started out with medical cost sharing. It's evolved into something much more powerful and useful, I think, in what we have. But the whole idea behind it is you're not stuck with the employer picking 1, 2, 3 plans. Hope they're good plans. Hope everybody's doctor's in network. The employer's responsible for the group plan. They've got fiduciary responsibility for the whole thing, which some of them don't even realize that, but they do.
Oh, yeah.
And we take that all away. When we implement our solutions, we take that all away from them. They don't have to do that anymore. Now they're giving their employees a plethora of choices, some traditional, some non-traditional. And it's up to the employee, how do I want to do this? It's very similar, and a colleague of mine, Kevin Skiffington, does a really good job of explaining this is like the 401k of healthcare. What we're doing is we're unbundling your pension plan, right? Everybody used to have a pension plan back in the day. That's why you stayed at a company for 30 years because, hey, I got a pension plan. I don't want to lose that. 401ks come along and it's like, oh, now I've got control over my money. Company's still contributing to it. I'm contributing, but now I can choose where I want that to go and how I want to use it. Same thing here. It's almost an exact replica of what went on in that industry to what's happening today in the healthcare industry, the health insurance industry. See, I just did something that I get on people for all the time. Healthcare is not a problem in this country. Health insurance is a problem in this country.
Right. Well, yeah, I would say those two go hand in hand for sure. But yeah,
well,
no, I agree. I see your point. Yeah.
Everybody wants, one of the big talking points is transparency, price transparency, right?
Yeah. Oh, yeah.
So with a group health plan, with my whatever plan I have, name a carrier, I don't really know what anything costs, really. Do I? I mean, I don't. I know what my copay is. I know what my deductible is.
Yep.
I'm not really sure when they kick in. I'm not really sure what to do with them. But with our plan, if you walk in and you say, hey, what's a self-pay rate? What's the cash rate for that? That's as transparent as it gets because they'll say, well, for an MRI instead of $4,000 that we're going to bill United Healthcare, we'll give it to you for 600. Gee, thanks. So
Yeah.
that's the kind of thing that's where we live, and that's the kind of thing we do. And then we have, as you know, we have a bunch of pieces around that complement the whole offering and make it really a full featured plan that give people better access to the healthcare system at a lower cost, both on a monthly basis and when something happens to them. It's all less. It all costs less.
Right, right. Yeah, and that's where as we've rolled this out to, again, even internally, just to our firm here at GBS, let alone our clients, is it is a little bit different process, right? It is a little bit different, claims process and such. And one of the things I like to point to is we've got somebody in our office that the first time she went to go use this, she had to go get a physical, and there were some other things associated with that. But so she didn't, she just kind of said at first, like, hey, what would this cost, right? Like, let's say I've got insurance. What's the insurance cost? And this lady took a few moments on the other end of the line and said, oh, it's $456. And she said, oh, okay, well, I actually don't have insurance, right? Because we coach people on, hey, you're a cash patient. So she said, I'm a cash patient. So knowing that, what would this same visit cost? Oh, well, if you're a cash patient, it's $276. And then before she even said anything, then it was like, oh, but wait, but if you pay the day of your visit, it's $197. And hey, if you need financial aid, ma'am, we can help. We've got form. So the point is in the healthcare system, when you're using health insurance to access it, there is not that transparency. And the funny thing is too, is a lot of times, and I've seen examples of this too, where it's like, it depends on what your insurance is. So like if she would have said, oh, we're with XYZ carrier, maybe it is $456. If you're with ABC carrier, then, oh, okay, now it's $550, right?
Yeah.
I mean,
Different network contract. Yeah.
Different network contracts, different charge masters. And a lot of this is stuff that employees don't necessarily want to have to think about or any of that. But it's also the reason why we're seeing that out-of-pocket maximums for a family are north of $20,000. And we're seeing that it's, I thought this reached a unsustainable point 5 or 10 years ago, but let alone the situation that we're in now. So, I think there's more people that are taking agency of accessing the healthcare system or getting the care they need. And there's so much more of a focus, I feel, as though these days on, mental health and on physical health and the food that we're putting in our bodies and all these kinds of things. These programs that we've put together, these strategies, the co-op, the cost shares, the ICHRA, when you're using these together, you as an employee, you can't just simply take that card in and say, okay, here's my insurance card, do what you need to do. There is a little bit more that's required, but I've seen this firsthand, and I know our staff has, and certainly some of our clients, is that they're more than happy. Once they do this, they're like, oh my gosh, why hasn't it been this way forever? Why hasn't it been done like this since the very beginning, where I do have transparency into what I'm paying for, right? As we do in every other, transaction and stuff like that. So as we'll get into a little bit more about the strategies around co-ops and cost shares, because I was doing a lot of that prior to 2020 as well. As you know, Steve, and as most of my audience knows, I think, I'm here in Washington, where we'd done a lot of work with these different cost shares that were out there. And then our insurance commissioner said, no, we don't like you guys doing business in the state of Washington. So then we couldn't do that. We had to unravel that. And actually one of the plans that we had for our firm was one with one of those cost shares that we ended up having to make a big change because of state regulations. And that was frustrating because we did have some clients that really liked that model. And for whatever reason, it was something that was threatening to our insurance commissioner's office. But at any rate, what we've seen now with having this co-op option available is it's very similar to those cost shares and stuff like that. So I was going to move on to the ICHRAs first, but let's touch on that first because I think that's an important conversation. I think there's a lot of us out there that saw these cost shares. Those were things that really started to. There was a lot of them that came on the scene right after the ACA was passed and implemented. Was we started to see these cost shares of there were groups of people that didn't necessarily agree with some of the tenets that were built into that ACA and stuff like that, and so there was varying effects and varying degrees of success with some of those. But overall, it's a strategy where, again, it goes back to, look, I don't have insurance, health insurance. I'm a cash pay patient, and so that's really kind of the core tenet of that.
Right.
But yeah, let's maybe dive a little bit deeper on that part of the strategy, and then we'll shift gears and talk a little bit about the ICHRA.
Okay, yeah. We use a cooperative, a healthcare cooperative, instead of medical cost sharing now. And we've done that for close to 3 years now. And it's because, well, the vendor that we are tightly connected with created this product. And they do a very good job of managing it. But the real crux of it was that it's as simple as co-ops are managed and overseen differently than health shares. So
Mm-hmm.
from a Department of Insurance standpoint, they have no problem with co-ops in the state of Washington. We've implemented a number of them with you. You've helped us implement those. They do have a big problem with health shares for various reasons. And there are some good ones, like with anything else. There's some good ones and there's some bad ones.
Oh yeah.
Um, that goes with anything. But we went with the co-op route because it was just easier to implement. It's easier to, even though it has some of the same concepts as sharing, it's just an easier lift and it's easier to use and there's more flexibility in it. I'll just say all those things. And part of that is the co-op structure, and part of it is the company that offers the co-op, Health Access Solutions. They do a really good job with members of the co-op getting the claims paid on a timely basis, turning money around quickly. They're just very, very good at what they do. So it creates not frictionless, but less friction situation for the member.
Right. Well, in addition to the costs are a lot less to begin with,
Oh,
right?
well,
The
yeah. I mean, that's not even close.
No, yeah, exactly. Well, and we've seen it again firsthand. I've one of our clients is somebody who he went and used it right away, as did his wife. And one of the things he was telling me just a couple weeks ago is he's like, yeah, I need to get his only complaint was I need to get my ACH set up because I got these 3 reimbursement checks sitting in my car. I just need to remember to go, deposit them at the bank type of thing. But how quickly that they were able to get that resolved. And I think the other important thing to point out too is, well, 2 things. One is, again, as everybody has heard me talk about, we build 21st century health plans, modernizing healthcare, eliminating employees' out-of-pocket expenses, guiding them to higher quality care. So a big key component for me in doing that over the years has been to put in place a medical advocacy, nurse navigation, nurse concierge, whatever you want to call it. I call it a number of different things, but essentially it's a service where you've got a nurse that you can reach out to that can help you navigate the healthcare system, that can help give you perspective on where to go and get an image done, or where to go to have this diagnostic, or what top quality doctors are accepting new patients, research specialists for you, research primary care doctors for you, and really almost in some ways kind of be a virtual primary care, or almost like like telemedicine or something like that. So now that's something that we have baked into these programs as well, and that's something that not only can they help you from that clinical standpoint, but as I've been able to observe, is they also understand how these co-op and cost share plans work, so they can help you navigate. Hey, I just don't understand where to go to submit this reimbursement. Oh, okay. Well, then the nurse can help you with that too, which is super cool. And I think when a lot of us, a lot of the way that we want to work with businesses today. I mean, everything is so customizable, right? And that's just the age of that we live in. And there's no better example of having that nurse concierge that understands the clinical aspect of where to go in and get seen, but also understands, as I just said, they understand how these plans work as well. So you can help you navigate both sides of that fence so that you're not left wondering, okay, what am I supposed to do? Who am I supposed to reach out to? Not necessarily really having an advocate. And now that is something that we do, bake into those programs to help people understand and just to help them navigate this new way of accessing the healthcare system, which again, as I mentioned at the very beginning of this, is goal number one. Just get me access to doctors, facilities, hospital, whatever it is. That's what I want. It's not all this other confusing, convoluted stuff, right?
Yeah, I want access to them and I want the ability to pay for it. That's the two things. And you're right about the advocacy group. And we use Modern Health for that. Their nurses, like you said, they understand our plans very well. So they understand how to use them, how to get reimbursed. And what we found, and the reason we started embedding them in every plan we do, is because when you're changing the mindset of the employee base, because they're used to there's a lot of comfort in that medical ID card, right? That
Oh yeah.
Anthem card, UHC card, whatever carrier they're using, Regents, they have a comfort level with that. And as a business partner of mine used to say, Steve, you got to remember, people are comfortable with a certain amount of familiar pain. So even though it's painful, that monthly premium they pay, I'm pretty comfortable with this. So we had to find a way, and we're continually finding ways to give them resources to help them navigate this new way. And the concierge is part of that. Not only are they virtual care for you, they're care navigation, they'll help you with prescriptions, they'll get, look up stuff for you, they'll help you file a claim. So it's all kind of an all-encompassing thing. We've even started adding a way that employees can pay for the care without coming out of pocket, have those funds, whatever they paid, if they have a $300 expense at the doctor's office, even if they're going to get reimbursed, while they're waiting reimbursement, they can say, you know what, I want to spread that out over 10 pay periods, and it'll be done via payroll deduction, and it never comes out of their account. They get reimbursed for it, and they pay it off. So and there's no interest and no fees for the employee for that. So we're always trying to find ways to help smooth the process out for them.
Right. Yeah. And that's where I was going to go next with that too, is that, when you go in and you say, hey, I'm a cash patient, and they're used to paying, maybe a $30, $40, $50 copay or something like that. And suddenly, oh no, you're on the hook for $150
Right.
or whatever the case is. There are certain people that don't
It's
have
hard.
that, or they don't, they'll avoid care. And that was, something that we saw even with people that are on these traditional ACA, PPO kind of plans or HSA plans, if they're not contributing to their HSA account, perhaps. So no, that's an important call out, and that's where I was going to go next with that too. Is where do you go if that is, how do you deal with that if that is the case? Because that's certainly been something that's come up with a few of these groups that we work with, and that type of thing. So. Now, one of the other things too that I was going to shift to and talk a little bit about was in those cost shares, and this was the challenge I ran into pre-2020, before COVID, BC, so many years ago, right? One of the things I ran into was, like, especially with those cost shares, and it's the same way with the co-op plan as well too. Is there is an earn in, or there is a probationary period, or there is a cap essentially on the benefits that you can receive if you're on one of those plans for pre-existing conditions, right? Yeah. So, and just for those conditions that you already have prior to coming into one of those plans or into the co-op or that type of thing, there would be some consideration around, well, gee, this isn't going to work for me because I'm 7 months pregnant, or my wife is, or I've got, I've got cancer, or I've got this surgery coming up, or I've got this or that. And in those situations, it would be like, it would always kind of like, well, what do we do here exactly? Well, since 2020, where I'm going with this, obviously, is folding in ICHRAs. Was I initially I started using that as kind of a carve out. So the famous example I like to use is I had a client that came to me in 2020 and said, "Hey, this was a group that was up in Washington. They're on Kaiser. They were on the HMO plan. And they said, "Hey, great news! We've got a couple new employees, but they're out of state. They're down in Texas."
Yeah.
And it's like, "Oh, okay. Well, obviously they can't participate in this Kaiser HMO plan, being that they're in Texas, and Kaiser has no, there's no option for them down there, other than out of network. But that would be silly." So that's how I accidentally stumbled into my first ICHRA, was writing a couple policies and putting together an ICHRA plan, and then writing. I actually referred that out to somebody that I know well down in Texas, who ended up writing those policies. But to me, it was, look, I'm solving a problem for my client here. I'm making sure that their employees down in Texas have at least something, that they're not just left out in the cold because they happen to live in an area that Kaiser's doesn't operate in. So that was initially kind of how I found it, but then also not realizing at the time. But then where I'm going with this is that, for those cost shares or those co-ops are maybe not going to be the right fit for everybody right at that moment. So then what do you do for those people that either have to have something outside of that, or, to your point earlier, the devil they know is more familiar than the one they don't. So they would rather keep that same logo that they've got on their ID card, know that they've got, a network that they can access, and use that traditional insurance path. We're offering basically a fork in the road where they get to decide what is best for them. And that's where you talked about getting the employer out of the group business. They're not now deciding, here's the carrier we're going to use, here's the network, here's the 2, 3, 4 plan designs that we're going to use. Now you're saying, hey, look, you're flipping that on its head and doing it in reverse and saying, okay, this is what our employer contribution is, right? It's going to, be relatively the same year to year, but here's what our employer contribution is. The good news is, you as an employee, you get to decide, do you want to go down this path? Do you want to go down this path that you're more familiar with in the traditional insurance model? That's what the ICHRA allows for, and that's where I've seen it used most effectively, quite frankly. Because then the other thing is, too, while we're on this, I want to hear your thoughts on this too, Steve, but not everybody wants that traditional model, right? So if they have the ability to not have to go to Kaiser, UHC, Cigna, Aetna, United Health, whatever, they don't have to, right? So now everybody kind of gets a choice, and you're able to do the thing that everybody tells you not to do, which is to try and please everybody. But now it allows you to allow them, it allows you as an employer to allow your employees to have some of that decision-making power on their own, and decide what's best for them, what's best for their families. And again, maybe it's the cost share co-op path, and maybe it's the ICHRA path. But again, you're allowing them to decide. And then obviously we've got a team in place that can help facilitate that with education, application, and then ultimately getting enrolled and having something be effective on the desired effective date, right?
Yeah, exactly. I mean, you've hit the nail on the head. And it's all about choice, and it's all about giving the employee the power of choice. Now, that can be overwhelming too. And that's why you have to have behind the scenes, we have people that'll help them through that decision process. Because, last year I had to choose between 2 plans that my employer was offering. Now you're telling me there's 50?
Yeah.
Well, what do I do with that?
Right.
The good news is that if they go the traditional plan route, in most states, in most areas, there are very similar plans on the individual market that are very close to their group plan. Not exact, because there'll be people watching this saying, "Oh, they're not exact." No, they're not exact. I didn't say that. They're very similar.
Right.
Same carrier, same network, similar deductibles. But again, going back to the real power of this choice and the way this plays out is, most of the time in a family unit, it's 1 or 2 people that are driving some type of severe pre-existing issue, right? So Right now, in a group setting, the whole family is kind of forced into the same direction. The flexibility that we have with what we're doing here is that you can have the whole family on the co-op, and that one child or the spouse or whoever has this chronic condition that needs more care that the pre-existing limitation may not cover for the first couple of years, we can go get an individual plan for just that person. So now you've got a combination of things going on where we're starting the clock for that person on the pre-existing conditions, because it's really only a 3-year window that they need to worry about.
Mm-hmm.
You've usually got either 10 or 25,000 the first year that'll go toward the pre-X, 25,000 in the second, 50 in the third. The fourth year and beyond, there is no limit on the pre-X. So it's really only 3 years we're worried about here. So it's a short-term strategy to get to a long-term enormous gain. So you could have, a person can have all 3 layers of our plan, including a traditional plan. They can have 2 layers. They can have 1 layer. It's preventive, co-op, and traditional. So those are the layers. So it's completely flexible on how you want to do this and what member of the family needs to be on what. So it becomes this strategy for you. It's a health plan strategy for your family that is completely flexible and up to you. So
Right.
that's what I'll say about that.
Yeah. No, it absolutely. Well, we've got clients I know that have, we've got one client that has people in like 26 different states, right? So, it becomes trying to find a solution for some. But even we've got a new client we picked up this week where they've got clients they have employees in Kentucky and Indiana and Illinois. Like they have people kind of in that in all 3 of those different states, and so then it's like it becomes one of these things, one of these considerations about, okay, well, it depends on where you're domiciled. No,
Yeah.
you're stripping all that away,
Right.
and suddenly it's like these people that are in these different states, it's all based on the state that they're in and their own local market and
Right.
their own, so it really does, in my opinion, it really gives people more choice and more flexibility, into how they want to structure them getting access to healthcare, which
Yeah.
again is really what the ultimate goal is, in this case as well. So one of the things that comes up a lot, and I want to spend a little bit of time on this too, is while we're talking about ICHRAs, is the when you're it's individual coverage HRA, right?
Right.
It's that individual coverage piece, right? So like, somebody my age who's 43 is going to have a different rate even than somebody who's 44 or somebody who's 42, right? Like they're all age rated. All these individual plans are. So it becomes kind of one of these things of like, all right, well, how do we manage this from a contribution standpoint
Yeah.
if we've got, let's say, somebody in their early 30s that wants one of these ICHRA plans, that wants one of these individual plans in their state, and then how do we marry that up with somebody who's, say, in their mid 50s? Those
Yeah.
premiums are going to be much, much different. So how do we marry up the contribution strategy to make sure that it's somewhat fair and equitable for everybody, and we're not punishing the older employees by having just a flat dollar amount. We're not punishing them by saying, hey, you're responsible for a larger premium share, and then rewarding these younger employees just for the sake of the fact that they're a younger age, right?
Yeah.
So
Whatever the flat contribution is goes further for the younger employee than it does for
oh,
the old.
totally. Or
Yeah.
if not,
Yeah.
covers the entire thing.
Yeah. So
So yeah,
typically what we do is well, again, work with the employer. What's your current contribution strategy? So we're kind of trying to stay in that area. But what happens with the ICHRA side on the traditional plans is it's usually a tiered contribution structure based on age. So you start at 18 or 21. You start at 21, work your way to 64, because at 65, everybody goes to Medicare on our plans. And you just have this tiered approach that the 21-year-old might get $150. The 60-year-old might get $450.
right.
The rule in there is it can't be more than a 3-to-1 ratio. That's a technicality of ICHRA. The ratio has to stay within 3-to-1 from
Right.
the youngest to the oldest. So it's really that simple. It's not a difficult process. It's just you got to work through it with the employer because typically their contribution for the co-op portion of the plan for people that choose that is a little different. And a lot of employers, because it's so much less expensive, their current contribution structure makes the employee only version of the co-op and the preventive care completely free to the employee. And
Right.
and so there's these huge dollars flying around here in savings that everybody's getting. The employer's getting it, the employees are getting it, and then you have to. It's a strategy with the employer on how do you want to structure this? How do you want us to present this for you? Because this is a change, but it's a positive change financially and the way the product's built and used. So I don't know if that answered your question, but it's really
Yeah,
two
no,
different contribution structures is what it comes down to.
it is, and I think that there's a lot of employers are used to that now. I mean, even with a traditional kind of PPO style plan, a lot of times there's they'll have a certain percentage, let's say, or they'll pay 100% of the base plan for the employee only, and then any spouses or dependents are they're those are additional contributions that need to be made, or it's some kind of, and then if they want to buy up to a more benefit rich plan, then they're responsible for the difference on that employee
Right.
only tier. So yeah, we've seen it do a number of different ways, and we do have a few employers still who make contributions towards spouses and dependents as well
Yeah.
too,
Well, you
which
can
is
through the ICHRA, you can. Yeah.
oh totally yeah, and it's a rare thing to see these days, but it is something that still does exist. Yeah, so you're already kind of having to play around with those contribution strategies. And then we also have seen over the years, especially these last couple, where it's been a lot of double digit increases. And so we've had to see some of our groups have said, all right, well, we'll absorb part of this, but we're also going to have the employees do a certain amount as well. So a lot of times, rather than doing, say, a flat dollar amount, they'll do some kind of percentage, and maybe it's 90%, and then they move it to 85% if they get a 20% increase to have the employee help absorb some of that. Which is never a great thing. Or then they'll start changing the plan design and things like that, right? And then you're changing the plan design, and that's just hiding an increase, but it's still you're diluting, you're watering down the benefit that you're providing. And again, some employers feel as though they have to do that, but yet they don't like that, right? That's not good news to their employees. That's wiping away any kind of salary gains or any
Yeah.
increases that you're giving those employees, really. So so that's
Well,
been something that
that kind of goes to
that
the what you titled this session, right? It's about the renewals.
right. Well, that's where I was going next, but
Yeah.
go ahead, pick it up from
Uh,
there, Steve.
the thing about the renewal, sorry.
No, you read my mind. I love
I,
it.
I
Keep
don't I
going.
don't do that many of these. Nobody wants to talk to me, so I'm anytime I get the chance, I'm going to talk. Um, so renewals are really, and this is part of the initial presentation we do to the we tell the client when we're doing the financial analysis because that's a big part of this, and we're usually showing the numbers are usually the savings potential is usually enormous. But even as important as the first year savings is what renewal looks like. We
Right.
have over the last 6 years, we have a 98% renewal for this plan, this type of plan, this structure. And our average increase is 2%. The last 2 years, we've delivered 0% increase to our clients. So the renewal conversation becomes, you want to keep going? Yeah, I want to keep going. We're done. Now, the individual plans, the ACA plans, whether they're on or off exchange, those plans do increase every year. So those, and sometimes the contributions need to be adjusted by the employer to kind of keep up with that, depending on what's going on and what the area is.
Right.
But typically only 15, 20, maybe 25% of the employee population has chosen one of those plans. Everybody else is on the co-op because
Right.
of the way it works and the pricing. So it's a very small percentage of your employee population that we have to deal with that type of thing on. And overall, your renewals are very simple, very seamless, and you're not going to have a heart attack.
Right, right. Yeah. It really it takes the sting out of that. And I think the other thing too is it makes um it's far easier to budget for that, right? Like I mean, I
Yeah.
think with any of our expenses that we have, if you can, know or predictably see that you'll have a, 2% increase each year on that cost versus what we've seen. Again, I just look at the last, 2 years, what it's been. 20% has kind of sort of been the floor for what these increases have been, and you can't stack 20% increases on top, keep stacking 20% increases on top of each other, and expect that that's not going to have an impact in other areas of your business, or certainly on your bottom line, or different things as well. So yeah, no, I think that's a really important call out because that's one of the things where we've had a lot of success with level funding and self funding, even prior to doing the cost share stuff. But with level funding and self funding, because it we can smooth out some of those increases that we've seen, and in some cases we've seen big decreases, and we have seen those things level out a little bit. And having some of those solutions that are able to help mitigate, specialty drugs or just any kind of drug spend or whatever, we've got a lot of those things that we bake into those programs, and those things are all great, but you can still get hit with a bad renewal year. We've seen that too, right?
Yeah.
Whereas, yeah, this will help, but then when you shift to a different model and you can bring some of those cost containment solutions into that, it just further enhances the experience for the employee, and so it can take that pain away from making that change, because this is, as human beings, we're very resistant to change. We want things, once we've kind of settled in something, we don't want, to be disruptive, and we don't want to be disrupted, I guess, is what I should say. But yeah, no, I think that's an important call out, in that when we're structuring this differently, and the important caveat there is that because it's not traditional insurance, because you're a cash pay patient, you're not having to, this isn't a carrier that has to worry about their medical loss ratio, and where
Right.
does that fit, and where do you fit? If you're a small group, then are you in that community rated pool? Are you it's in a trust program where you're rated with all of these other groups? Are you in a captive? Are you level funded where you're, you know your experience, your claims experience for your people, is going to come into factor into what your renewal looks like, and things like that.
Yeah.
This strips all of that away, and yet for those that small percentage of people, you mentioned 15 to 25%. With the groups that we've brought into this it's been far less than that.
Yeah.
I
Yeah.
would say 10% has kind of
Yeah.
been the ceiling on that we've had less than 10% of folks that typically opt in for those individual coverage plans, and opt in for the ICHRA route. But again, it's providing that flexibility to everybody within the group, and then again being able to just manage this expense, which is typically number two, maybe number three on your P&L, and this is a way to mitigate some of those problems. On that note too, I remember there was a CFO who's a buddy of mine. I remember him telling me at one point, we were talking about his healthcare plan and all this, and he runs a firm that has about 100 employees, and then some seasonal folks too. Anyways, doesn't matter. But what he said to me was, he's like, look, if I want to change what we're doing strategically with the CPA firm that we're working with here, I can do that tomorrow, and that has no impact on anybody else except for me and the other people, his other accountants in his at his firm. But if I want to change what we're doing benefit strategy wise, that affects
Yeah.
everybody else here. So that's a big, big risk. And what pairing the ICHRA with the co-op, with the cost shares, what pairing those two strategies together, what that does is it helps minimize what that potential risk of change would end up looking like. So that's really, I think, the beauty of this is it's not just saying, here, you got to do the co-op, you got to do the cost share, or hey, you got to do the ICHRA if you want to get control of these costs. No, it's bringing that together as
Yeah.
a solution, as a package, and bringing that forward. and that really, I think, is the beauty in this, is that, again, you can do this in a way that threads that needle of making everybody happy and ultimately getting people what they want and what they believe is best for them. Whether, and I could argue that all day, but I don't really care to. I would, if you're happy with that
Yep.
logo on your ID card and you want that ID card, God bless you, great.
Keep
Then
going.
you can have that. Yeah,
Yeah, there's a reason we have a 98% renewal rate.
totally. Yeah, absolutely.
So, and it's
And I would venture to
that's
guess
it.
it's kind of like us. I mean, those groups that we do lose, or that are in that small subsect of ones that don't renew with us or move elsewhere. Typically, it's because they get bought by
Mhm.
a different company who's got their own ideas, and they're not bought into this, and that's fine, whatever. So now they go off and they've got somebody else, maybe out of state, who's making decisions for them. Or we've seen they just simply fold up shop, and unfortunately, we have seen that a few times too, where businesses just discontinue to operate, and that tends
Right.
to be another thing that we see as well. But yeah, for the most part, I think what we've seen is that, first of all, we're able to keep people happy across our entire book of business. But I think also, we continue to bring these solutions, and so we've had even we presented this co-op ICHRA model to pretty much everybody this last fourth quarter, because we'd seen some early success with it last year, and we said, at the very least, hey, we're going to get this in front of folks. This is not
Right.
necessarily, we're not, and we don't ever do this, right? It's their business, it's their decision, it's their money. They get to decide what they do. We can just simply be their guide, their Sherpa, show them what else is, show them the way, and then they decide what they want to do. But we did have a number of folks that looked at this and said, yeah, we're just not quite sure about this, but we appreciate this. We want to take a closer look at this maybe next year. So obviously, we did have some clients that moved over, again, including our firm, but that have been super happy with it. And so again, I think as they start to see some of that social proof, and they're able to see some of the case studies that we've started to put together, they'll also take a closer look at this. And I think there's, everybody is going to, at least in our book of business, everybody's going to see this at some point,
Yep.
because that's something we've prided ourselves on, is bringing some of these additional solutions, and again, building 21st century health plans. And we wouldn't be doing our job if we didn't bring these solutions to bear, and at least have conversations around them and show them where it's worked, and also where some of the challenges lie. And as we've talked about with having Modern Health, having the nurse concierge in place there, having the prepay option, and having that payroll deducted, having all of these things in place that help it go in a very seamless fashion. Because I think that's one of the things that people like about having those ID cards is, one, they've been conditioned to think,
Yep.
this is how I access the healthcare system, right? So to unravel some of that programming is going to take some time to be able to do. But if that's what they see as they need to be able to do, then great. Then again, then you can do that, and I'm not going to tell you otherwise. But we've got a solution built around that. So anyhow, sorry, I started rambling there, but
Well, that's fine. I,
what would you add to that, Steve?
well, you're no, you're absolutely right, and I think from the health plan advisor side of things, advisors, they need to, whether you want to do this or not. I mean, that's up to you. You got to run your business the way you want to do it. I think you should understand it and know how it all works, so you know how it. And I think this is what you were saying. So you know how it compares to the other things that you're offering, whether that's self-funded, level funded, unbundled, direct contracting. All that stuff's a lot of work. This
Can
is
confirm.
not nearly that hard, and it kind of
Yeah,
gets you to the same place.
yeah,
It gets your client to the same place, I think, in a better place. But we can argue. We'll argue back and forth on LinkedIn about that. But uh, but at least understand this from a broker point of view or a health plan advisor point of view, because the carriers are going to fight this. Obviously, they hate this kind of stuff. They're going to fight it, and it's. I'm old, so I tell stories about old things. There, if you think back to the late 19th century, early 20th century, who ruled the roost in the transportation business? Railroads, right?
Oh yeah. Yep.
Everybody traveled by railroad. Well, when the airline industry started to kind of come up and airplanes, it looked like they were going to be something. The railroad companies forgot they were in the transportation business and thought they were in the railroad business. And their head handed to them by the
Mm,
airlines who said, we're in the transportation business. Why didn't Union Pacific start an airline? I don't know, because they weren't thinking about that.
right.
Sears thought Walmart was this backwater thing over there in the hinterlands with all the hillbillies shopping there. And then they looked up and they went, oh crap, we're done.
Mm-hmm.
I think we're in a very similar paradigm with traditional carriers, traditional brokers that don't want to do anything new. I think there's some forward-thinking advisors creating new ways of doing things. It doesn't happen overnight, but one day everybody looks up and goes, "Whoa, that's not so weird anymore. It's actually the mainstream." And I think we're headed
Right.
that direction because the upward pressure of, you've mentioned this earlier, I've never seen a Q4 like this before from a triple or a over 15% renewal, the number of them.
Yeah. Oh yeah.
I mean, we were seeing 50, 60. We saw one that was, I think it was you and I. We saw one that was like 130.
Yeah. 124%.
How
Yeah.
do how do you do that? But people talk about this stuff and they say, I'll talk to employers and they'll say, oh, well, we only got a 7% increase last year. Did you just hear what you just said? Only a 7% increase. How much did you increase your prices to your clients? Not
Right.
7%. And do
Yeah.
you realize that a 7% increase every year that you think is wonderful is going to double your premiums within 8 years?
Right. Right.
It's just, we've almost been conditioned to, we're just, okay, hit me again a little, just don't hit me as hard. It's
Right.
like,
Yeah.
instead of stop hitting me.
Right.
So
Yeah.
I guess the other more recent example that I love to talk to people about is in the early 2000s, this little company called Netflix went to Blockbuster, right? We all remember Blockbuster, all the stores everywhere. Wayne
Oh
Huizenga
yeah.
owned the Dolphins, huge company, right? Everywhere, every Friday night, everybody went to Blockbuster to get their movies. Netflix shows up and goes, hey, why don't you guys buy us for $50 million and let's collaborate with this? Blockbuster laughed him out of the room.
Yeah.
Where's Blockbuster today? Netflix is worth north of 200 billion.
Right. Yeah. I
I,
know. That's
I'm not saying carriers are going away tomorrow and the traditional brokers are going away. I don't want anybody yelling at me about that, but it is incremental, and you better at least embrace what you don't understand or don't know. You better learn about it and figure it out.
right. Right.
Might not be good for you and your clients, and that's fine. But if you don't do it, your client's going to get a big increase, and some knucklehead like me is going to be standing in the door going, hey, can I show you something?
Yeah. Totally. Yeah, no, absolutely. Well, and even some of the business that we did last fourth quarter, there was quite a few of those were new opportunities where I just, I came in and just said, look, I'm not going to show you all this traditional stuff, all the same stuff that your broker is going to show you and any other competing. Here's here's the one solution I'm going to show you. And if you want to work with me, we'll do this. And if you don't, that's totally fine. Anybody can do what you're
Yeah.
doing already. This is something that's new and unique, and that's we picked up new business that way by just presenting this option. And I had a few of those groups that just said, just because of the nature of what we're already doing in terms of building 21st century model plans, they came to me saying, hey, I don't know exactly what you do, but it looks like you do healthcare but in a different way. So don't show me the same stuff. We want to see something different. And it's like, okay, great. Then that's what I'll show you. And in fact, I just had a meeting last week with I don't even know if I told you about this, Steve, but I had a meeting with a prospect, nice lady, very direct, very to the point. and got to the end of the presentation, and she completely got it. She completely understood. And she's like, I know that this is not a fit for us and for our population right now, but I know I've got two people that I need you to talk to. And she made introductions to these other, after this was after a 30-minute meeting with her. She made two introductions to two of her colleagues in the HR world, for me to talk to them about
Yeah.
this same solution. So yeah, I think that at this point, the not only the cost, but also again, just having the knowledge and having the understanding that somebody that doesn't necessarily use the healthcare system a lot, because we all have, every group has high claims utilizers.
Right.
Even the small groups are going to have one or two people, and then larger groups might have three, four, five, six, seven, whatever it is. We've all got high utilizers, so we've got some people that are very well versed in how to access the healthcare system and different things like that. And then we've got other people that maybe they have some kind of event that happens, an illness, an injury, or whatever it is, but they've never had to actually try to access the healthcare system. And in that traditional model, you're kind of just flapping in the breeze. You're on your own. Whereas in this model now, we've got somebody that can walk you through how to do it and where to go and what it's going to cost you. And not only that, but with the nurse concierge model, they can take care of pre-certifications, pre-authorizations, like any of those kinds of things that come up as well, which sometimes can kind of jam up the gears, depending on the situation. But we've kind of thought about that, and we've solved for that. And also, I think that what we've started to see is that this new generation of employees, that's coming in, especially these folks that are whatever it is, the people after the millennials and such, are starting to come into the workforce, and they do not want the same type of
Right.
health plan, and they do not want the same kind of experience that their parents and their grandparents have had as they've gone through the years and progressed through their career. So
You know what we didn't even talk about was the fact that our plans also give you access to direct primary care, brick and mortar direct primary care if you have one
oh
local.
yeah,
We didn't even touch on that, but it's
well,
there.
it is. And you know what's funny is that's the analogy that in the past I've used that quite a bit, when I'm talking about DPC, direct primary care, in talking about Netflix versus Blockbuster. That's always that's always kind of the comparison that I like to make too, between the fee for service Blockbuster, where you've got to go in every time and pay to rent your movie, probably pay late fees because their late fee policy was kind of wonky. You've got to weave your way through all that candy. So I didn't have kids when Blockbuster was like really still a thing, but had I done that, then the kids would be grabbing at whatever they can, and then of course you're also getting out of your house. You're going, like the whole thing. Whereas now with Netflix, you can just be sitting right on your couch, pull up, start watching whatever it is that you're wanting to watch. That's the DPC. That's the subscription base. That's the convenience side of it. That's where again, that's that customization that people are looking for. I mean, even your Netflix stuff now is they've got all these algorithms and stuff where they can help predict what show that you're going to want to watch next,
Yeah.
based on what you've viewed and what you've liked in the past. So no, that's an important call out, is that and I also, in addition to having all these things we talked about, I'm also using one of those DPC services. So
As do I.
yeah, which again, it's we eat our own cooking here. So anyhow, well, we've got just 1 minute left, Steve. I think that was a perfect good parting shot. But if there's anything else you'd like to add, speak now or forever hold your peace, I suppose.
No, I think we've covered everything. I'm not sure I have much more to say. I don't know enough more of anything, so I'm done. I've emptied my brain.
Well, good. As have I, and it's the top of the hour. So with that, thank you everybody for joining us today. That's Steve Alley. Make sure to connect with him on LinkedIn. And Steve, we're going to need to have you back on again soon. This was too much fun. So
I enjoyed it,
we'll do
Chris. I
this
really
again
did.
soon.
Thank you.
You bet. Thank you. Thanks everybody.
Okay.